Good afternoon, everyone. My name is Smriti, and I'm a placement student currently completing my Bachelor of Community Services placement at the Mental Health Foundation Australia. It's a pleasure and honor to be your host for today's webinar. Before we begin, I would like to acknowledge the Wurundjeri Woi-Wurrung people as the traditional custodians of the land on which I live and work. I pay my deepest respect to elders past, present, and emerging, and I extend that respect to all Aboriginal and Torres Strait Islander peoples joining us today. On behalf of the Mental Health Foundation Australia, I warmly welcome you and thank you for joining us for today's session. Today's webinar explores women's health across the life course, featuring two complementary presentations from leading experts at the Center for Women's Health Research. Together, this presentation brings decades of research and insight into how life experiences, particularly violence and mental health, will shape women's health outcomes over time. Our first presentation will be delivered by Professor Deb Loxton, Director of the Center for Women's Health Research on women's experiences of violence and health over the life course. Our second presentation will be delivered by Natalie Townsend, Research Executive Manager for Australian Women's Health Study on mental health and women over the life course. Introducing our first presenter, Professor Deb Loxton. She is the director of the Centre for Women's Health Research at the University of Newcastle and director of Australian Longitudinal Study on Women's Health. Her research over the past 2 decades has centered on women's health across the lifespan with expertise in the impact of violence over the course, maternal morbidity and mortality, longitudinal research methods. Her work has significantly influenced national policy, including National Women's Health Strategy from 2020 to 2030, government responses to COVID 19, and the plans to end violence against women and various mental health policies. Introducing our second presenter, Natalie Townsend. She is the Research Executive Manager for Australian Longitudinal Study on Women's Health at the Centre for Women's Health Research. She holds a Bachelor of Psychology with first class honors, a Master of Clinical Epidemiology with distinction, and is currently completing a PhD in Public Health. Natalie has worked in women's health for over a decade, specializing in mental health, the impact of violence and abuse, longitudinal study design, research, translation and communication, participant recruitment, and project management. Now, let's welcome our speakers. Please join me in welcoming Professor Deb Loxton and Natalie Townsend.
Thank you, Smitty. That was a really nice introduction. We appreciate it. Nat will be driving the slides today, so I'm going to ask her if she can please pop the first one up, and then you'll just have to put up with me saying next slide, please, every now and again. Welcome everyone to today's presentation. It's our pleasure to be here and to talk about some of the findings from the Australian Longitudinal Study on Women's Health. As Smitty mentioned, I'm the director of that study, plus also the Centre for Women's Health Research. And of course, I'm joined by Natalie Townsend, who is our Research Executive Manager. Today, we'll be talking about two priority areas for mental health, including the outcomes for women who've experienced violence at any point during the life course, and also the mental health of young women in Australia. Next slide, please, Nat. So, as I said, we'll have an overview of the longitudinal study, then I'll be talking about violence and mental health, and then Natalie will talk about mental health of young women. Next slide, please, Nat. Before I begin, I would like to acknowledge the many countries on which we work and also the many countries across Australia where our participants reside. At the University of Newcastle, the longitudinal study is conducted on Awabakal, Worimi, Wonnarua, Boonwurrung and Darkinjung lands, and at the University of Queensland on Turrbal and Yuggera lands. We have participants from across the country, and we acknowledge those many lands and the traditional custodians of all of those lands. Thank you. The longitudinal study is a national research resource, first funded in 1995. It exists to provide the evidence base for the development and evaluation of policy and practice in areas of service delivery for Australian women. It is jointly managed by the University of Queensland and the University of Newcastle. Natalie and I, both from the University of Newcastle. Next slide, please. The longitudinal study has participants from across the country. More than 57,000 women complete regular surveys. On this map, one purple dot represents a place where at least one participant lives. And as you can see, it emulates the way that we live in Australia, with the majority of the population being around the coastlines. Next one, please. The study is comprised of 4 age cohorts who were born 1989 to 95, 1973 to 78, 1946 to 51, and 1921 to 26. That oldest cohort was 70 to 75 when the study started in 1996, and are now aged 100 to 105. There are about 100 women remaining in this cohort, with about 35 continuing to fill in surveys. For this cohort, they complete short surveys once every 6 months. And we just think it's amazing that these women are still taking the time out to influence and support women's health. The other 2 original cohorts were aged 18 to 23 and 45 to 50 at the start of the study. They are now aged 48 to 53 and 75 to 80. The youngest cohort, born 1989 to 95, were recruited in 2012 to 2013. They were then aged 18 to 23 and are now in their 30s. Next slide, please. The study takes a biopsychosocial view of health, and as a result, conducts research across multiple research areas. So in addition to the usual questions about physical and mental health that you would expect, we also ask about health behaviour, roles and relationships, people's experiences of work and transitions through major life events, such as having children or not having children, and the roles that women have, such as caring roles. In addition to that, we ask comprehensive questions about their experiences of violence, both in adulthood and childhood. Next slide, please. In addition to the surveys, we collect linked data from a range of sources that you can see here on this slide. The ones used most frequently are Medicare data in the form of health services use, the MBS, and pharmaceutical use, the PBS, as well as hospital admissions data for every state and territory. Next slide, please. In addition to that, we have a qualitative data set that has arisen from answers to this question: have we missed anything? We now have more than 86,000 free text comments collected from over 28,000 women and numbering nearly 4.5 million words. Every comment made by a woman is read when the survey arrives, and we use it to do things like identify additional health issues and to see what's most important for women at any particular point in time. The data have also been used for traditional qualitative analysis, including thematic and narrative analysis, looking at things like emotional distress, relationships, health-seeking behaviours, and experiences of violence. Next slide, please, Nat. For today's purposes, you'd probably be interested to know how we've measured violence and mental health. These are the things we'll be discussing today at any rate. Violence measures have included detailed behavioural measures of domestic violence, including the Community Composite Abuse Scale and the abbreviated form of that, the Adverse Childhood Experiences Scale, and we've also collected information about experiences of sexual violence, both in childhood and adulthood. The mental health measures include the Mental Health Index of the SF36, which is a short measure looking at the impact of emotional well-being on quality of life. We also measure psychological distress using the K10 or the Kessler 10, which many of you will be familiar with. We measure symptoms and diagnoses of anxiety and depression. We also ask about self-harm and suicidal ideation. Next slide, please. So I'm going to turn my attention now to focus really on experiences of violence and mental health over the life course. In this part of the presentation, I'll be looking at domestic violence, sexual violence, violence experienced in childhood, and then any violence. Next slide, please, Nat. When it comes to domestic violence, 26% of the women who were born 1989 to 95 had experienced domestic violence. 30% of women in middle age had experienced domestic violence, and 23% of women aged 71 to 77 reported experiencing domestic violence. These women wrote, "Previously, I was involved in an abusive relationship which affected both my physical and emotional health." And another woman wrote, "I was mentally and emotionally abused by a past boyfriend. Although it was not physical, it caused dramatic health problems, including drastic weight loss of about 20 kilos within a 2-month period." And throughout the comments, we find women making this very strong connection between their experiences of violence and their health and well-being. Next slide, please. And this is reflected in their quantitative data. This graph shows two groups: those who've never been in a violent relationship, displayed here as a green line, and those who have ever been in a violent relationship, represented by the purple line. This is the K10, where higher scores reflect greater levels of psychological distress. And this time period covers from 2012, when women were aged 18 to 24, until 2023, when women were aged 28 to 34. And so right across the early adult years, we can see that women who've experienced domestic violence have consistently higher levels of psychological distress compared with women who have not experienced domestic violence. Next slide, please. This slide shows the mental health inventory scores, where higher scores represent mental health. So on this graph, you want to be up the top. Again, the green line represents women who've never lived with a violent partner, and the purple line represents women who have. And here you can see from the time women were aged 18 to 23, right through to middle age, so a period of 28 years, there is a consistent impact of domestic violence on mental health that doesn't really change. Although the shapes of the lines are the same, reflecting things that happen as we age, that deficit associated with mental health can be seen here from the time women were aged in their early 20s right through to middle age. Next slide, please. And with this slide, we pick up the same measure, but for women who were born 1946 to 51. So here we're going from middle age into the sort of early old age years of the 70s. And again, we see a deficit in mental health associated with experiences of domestic violence that lasts right across this study period, which in this case is about 16 years. Go to the next slide, please. So what helps? What I've shown you are some graphs that really indicate that there's a lifetime deficit associated with experiencing domestic violence. But among women who've experienced domestic violence, we find things like not having a healthcare card, having higher levels of education, and ease of managing on available income are associated with better health outcomes. These three things really represent higher socioeconomic status and a greater freedom, perhaps, to be able to take care of health and well-being. We also find that higher levels of social support are associated with better health outcomes among women who've lived with domestic violence. Social support includes things like having someone to talk to, maybe having someone help with housing, or just simple things like a lift to the doctor. Social support can be provided by friends and family, but can also be provided by services. This woman wrote, "Friends overseas have been fantastic support. GPs, psychologists, and DV support have been a huge help." Next slide, please. We turn our attention now to sexual violence. And some of you may have seen a report that Natalie led a couple of years ago, where we found that more than half of women aged in their 20s have experienced sexual violence. This is a much higher figure than has been found by other studies and by other national surveys. We found a third of women who were in middle age had experienced sexual violence, and 27% of women in their 70s had experienced sexual violence. Next slide, please. If I was to show you the graphs for sexual violence and mental health, they would look pretty much the same as the ones for domestic violence. So we'll sit here with a summary. Sexual violence is related to poorer general health, an increased risk of chronic conditions, an increased risk of sexually transmitted infections, an increased risk of anxiety and of depression, and an increased risk of psychological distress. Next slide, please. This is a research preview, so this is a paper that we're currently working on, looking at sexual violence, self-harm, and suicidal ideation. Interestingly, self-harm and suicidal ideation weren't really focused on in the National Plan to End Violence Against Women and Their Children, and there's been a more recent push to have a focus on these two areas of wellbeing that have been largely put to the side. Compared with women who've never experienced sexual violence, those who were born 1989 to 95 and who had experienced sexual violence in the previous 12 months were twice as likely to have self-harmed in that same time period and 1.5 times more likely to have had suicidal thoughts in that same time period. Results were even more dramatic for women born 1973 to 78. Compared with women who hadn't experienced sexual violence, those who had in the previous 12 months were 4 times more likely to have self-harmed in the previous 6 months and 3 times more likely to have had suicidal thoughts in the last week. This woman wrote, "As a result of child abuse, sexual and physical assault, I have been hospitalised for mental health about 6 times, usually following a suicide attempt. I've had 2 intensive care unit hospitalisations for a suicide attempt so far this year." Next slide, please. So what helps? In results that are quite similar, but not exactly the same to those for domestic violence, we find that factors associated with good health among women who've experienced sexual violence include physical activity and social support in the form of emotional support and guidance and affection and social interaction. When it comes to mental health, the results are the same, with the addition of tangible or physical assistance to the forms of social support that have helped women who've lived with sexual violence. Tangible and physical assistance include things like providing housing, maybe providing a loan of money, and again, simple things like being given transport. Next slide, please. We're looking now at abuse in childhood. And this slide shows the percentage of women who report psychological distress from the cohort born 1989 to 95. And here you can see right through the early 20s that those who have a history of experiencing violence in childhood are about twice as likely to report psychological distress compared with those who've not had that experience in childhood. Next slide, please. Now, this slide really is an extension of the one before, although this time looking at mental health. The coloured in shapes represent women who have a history of violence in childhood, and the empty shapes represent women who have no history of violence in childhood. And across the 3 cohorts, we see a deficit in mental health, which is attributable to that violence experienced in childhood that lasts from the time women are 20 right through all 3 cohorts until they were 70 years old. One thing you might notice here is that regardless of whether or not women have experienced violence in childhood, younger women have poorer mental health than older women. This is a generational difference where each generation seems to have more mental health problems than the generation before. And as you can see, our youngest cohorts seem to be the most prone to having psychological health issues. And Natalie will speak more about that in her presentation. Next slide, please. So we did wonder what we are missing by focusing on violence in the way that we do. And by way of an example, this woman wrote, "I have for one experienced physical and verbal abuse from a sibling, and I'm sure that many other people have. This has greatly affected me, yet I find that the only form of abuse that is always advertising help is domestic violence from a partner. I think it would be nice to offer help to people like me. And next slide, please. So we asked ourselves, what if, instead of thinking about violence as being domestic or family or child abuse, we looked at violent acts regardless of who the perpetrator was or when it occurred in a woman's life? So instead of looking at the perpetrator or the time when the violence occurred, we just looked at sexual violence, physical violence, and emotional violence, and had a look at the prevalence and health impacts of these from when women were aged 28 to 34 until they were 43 to 48. Next slide, please. And these are the results. So on this graph, the blue line that goes from left to right across your screen as you're looking at it represents never violence. So at the beginning of the study period, 47% of women indicated that they had never experienced any of these forms of violence at any point in their life. Over the study period, you can see that the size of this group diminishes as women experience violence as they get older. By the time women were aged 43 to 48, only 26% of them indicated that they had never experienced any form of violence, which indicates 74% of women have experienced a violent act of some sort by middle age. You can see that women move from that blue group into one of three single experiences of violence, being sexual, physical, or emotional violence, represented here by orange, green, or red, or they move down further to have experienced more than one form of violence. The final grey group down there at the bottom represents women who've experienced physical and emotional and sexual violence. Only 9% of women reported this at the beginning of the study period, but at the end of the study period, 26% of women were reporting that they'd experienced all three forms of violence. Next slide, please. Having a look at violence and mental health, that's the any form of violence, we find that women across the three younger cohorts are 70 to 100% more likely to report a recent diagnosis or diagnosis of depression. 48 to 69% are more likely to report a recent diagnosis of anxiety, and 41 to 77% more likely to report high levels of stress. Next slide, please. And you can watch this space for some work that we currently have underway. We're looking at a longitudinal examination of anxiety symptoms and disorders in relation to domestic violence, the role of optimism in women's experiences of domestic violence, trauma-informed care and telehealth service provision, and also an exploration of domestic violence service provision during COVID, which was, as you may know, greatly affected by lockdowns and so on. Next slide, please. I'm going to hand you over to Natalie now, who's going to focus on the mental health of young women in Australia.
Thanks, Deb. So at their most recent survey, 41% of women born 1989 to 95 reported high or very high psychological distress. You can see here that as women in this cohort have gotten older, the proportion of women reporting high or very high psychological distress has decreased slightly, but the rates of psychological distress for this generation remain high. Now we'll have a look at recent symptoms of anxiety. Younger women were more likely to report recent symptoms of anxiety than older women, with 31% of women aged 28 to 35, 16% of women aged 46 to 51, and 6% of women aged 71 to 76 reporting sometimes or often having episodes of intense anxiety in the previous 12 months. As far as diagnosis with and treatment for anxiety, younger women were also more likely to have ever been diagnosed with or treated for anxiety than older women, with 63% of women aged 28 to 35, 36% of women aged 46 to 51, and 32% of women aged 71 to 76 having ever been diagnosed with or treated for anxiety. Here are a couple of quotes from our participants regarding their experiences of anxiety. The first woman wrote, "Started on medication this year to help generalized anxiety disorder in combination with regular psychologist appointments. Have been seeing psychologists since 2013, but just reached a point where I expressed the need for more help. It just wasn't getting any further. I felt stuck." The second woman wrote, "I was not diagnosed at the time, but had high levels of anxiety in the months after my first child's birth. These resolved over time and were not present until I became menopausal. I became quite anxious about things that didn't normally worry me. My sleep was affected and I developed joint pain. Having been on hormone replacement therapy for the last 3 months, these issues have been resolved." Younger women were also more likely to report recent symptoms of depression than older women, with 40% of women aged 28 to 35, 25% of women aged 46 to 51, and 20% of women aged 71 to 76 reporting sometimes or often experiencing depressive symptoms in the previous 12 months. Younger women were also more likely to have ever been diagnosed with or treated for depression than older women, with 60% of women aged 28 to 35, 44% of women aged 46 to 51, and 33% of women aged 71 to 76 having ever been diagnosed with or treated for depression. Here's a quote from a participant regarding her experiences of depression. She wrote, "In previous surveys, I've never reported experiences of depression. Earlier this year, I struggled with my mental health greatly. I started a new career as a teacher and felt completely overwhelmed with the workload, pressure, and a complete lack of support. I felt completely down, withdrew from friendships, constantly feeling like I couldn't cope and look after myself. I tried to talk to a counsellor for the first time in my life. The Employee Assistance Program service cancelled 2 appointments I made and I never spoke to someone." Now just focusing on our youngest cohort and their experiences of self-harm and suicidal ideation. It looks like rates of self-harm and suicidal ideation for women born 1989 to 95 are reducing slightly as women age. In 2019, 10% of these women reported self-harm compared to 6% at their most recent survey, and 30% of women reported suicidal ideation in 2019 compared to 22% at their most recent survey. It's important to note that even though self-harm and suicidal ideation have reduced in this cohort, 22% of women experiencing suicidal thoughts in the previous 12 months is still very high. According to AIHW, suicide was the leading cause of death in 2014 for women aged 15 to 44. As far as other mental health conditions in this age group, 18% have ever had an eating disorder, 20% have reported post-traumatic stress disorder, 7% have reported borderline personality disorder, and 6% have reported bipolar disorder. If we combine all of these different mental health conditions together, we actually find that 73% of women born 1989 to 95 have ever experienced at least one of these conditions in their life so far, and they're only aged 28 to 35. So what factors put women at higher risk of experiencing poor mental health? Some risk factors we've identified include a history of experiencing violence, difficulty managing on their income, a history of poor mental health, a household member in childhood with a mental illness, and poor social support. The good news is that there are things that help protect mental health and prevent mental illness. There's also evidence that when treatments are available, women have better mental health outcomes. So factors that protect against poor mental health include the ability to manage on available income, higher levels of education, physical activity, and 3 different types of social support. Here are some quotes from women regarding their experiences of mental health and social support. The first woman wrote, "This has been a difficult year for me. I'm sure I have been feeling depressed in recent months and am working to manage this. I'm thankful for the support of a loving partner." The second woman wrote, "Life is busy with kids and career, and meditation and mindfulness helps to manage my own expectations and feelings of overwhelm. I also have an amazing friendship group and loving family, which contributes immensely to my overall health and satisfaction." So we looked at women's use of mental health services and their mental health over time. In this graph, the open circles are women who had a recent mental health consultation, and the coloured in circles are women who did not have a recent mental health consultation. On this graph, higher scores indicate better mental health, so we want to see circles at the top of the graph. You can see that across generations and ages, women who have had a recent mental health consultation have better mental health than those who haven't had a recent mental health consultation. So the good news is mental health services really help. Here are some quotes from women regarding their experiences of mental health services. The first woman wrote, "I was diagnosed with anxiety around 18 months ago. It has had a major impact on my daily life. I am lucky to have a supportive husband and a doctor and a psychologist, plus medication, to help me." The second woman wrote, "I also had mental health crisis approximately 1 month ago and have since increased medication for depression and started seeing a psychologist. Both changing jobs and increasing medication, seeing psychologist, have improved my mental and physical health immensely." So to summarize, the best predictor of present mental health is past mental health, signifying early identification and intervention as critical. Overall, younger women were more at risk of experiencing mental health issues than older women. Younger women are also more likely to report experiences of violence. Experiences of violence are linked with poor mental health, regardless of the type of violence experienced and when the violence occurred. Social support, physical activity, higher education, and ability to manage on income are associated with better mental health, and these factors were also a positive influence in the context of experiences of violence. Women who had a recent mental health consultation were more likely to have better mental health than those who had not. And finally, this work leads us to 4 main recommendations. Firstly, given the high rates of poor mental health among young women, there is a need for mental health screening to begin prior to the antenatal period and continue across the lifespan and include questions on past mental health issues. We know that services and other support, such as informal and formal social support, are linked with better mental health for women, and particularly those who have experienced violence. So barriers to accessing support, such as cost and availability, should be identified and addressed. Mental health professionals should also be adequately trained to provide support when women disclose violence, and when they have appropriate training and referral pathways in place, to routinely inquire about experiences of violence. We'd like to acknowledge the Department of Health, Disability and Ageing for funding the study, and also the women who donate their time to take part in the study. And here are our contact details if anyone would like to get in touch.